Hi everyone, I'm John from HTN and welcome to this webinar today where we will focus on and discuss how digital can support preoperative assessments. And we are joined by a panel to share how Nottingham University Hospitals and Alder Children's Hospitals alongside Isla Health's digital platform have streamlined preoperative assessments. And I'm really pleased to welcome our panel joining us today. We have Abby Burrows, the pre-op prehab an NC-SEM matron and ambulatory care at Nottingham University Hospitals, Dr. Katie Misselbrook, consultant paediatric anaesthetist at Alder Children's Hospital, and Dr. Lara Mason, the director of product at Isla Health. So just a couple of housekeeping things to cover before we start. If you have any questions, type them into the chat and we'll pick them up as we go, and we have a planned Q&A towards the end of the session as well. I'm really keen to hear your views, your comments, so feel free to share anything in the chat. And finally, this session will be recorded and there will be a write-up done by the HTN team so you can read or watch the session back at a later date. So to frame the session, we know that preoperative assessments are crucial for preparing patients for surgery. However, the process can be time-consuming, potentially cause delays when patients are deemed unfit. So in this webinar, we will share how switching to digital and a digital-first approach that focuses on early screening and patient-initiated updates can transform the process. And we'll share how that translates into improving care and reducing waiting times and creating a surgical pathway that is more efficient, more scalable, and seamlessly connected. So a great session we have planned for today. I think a good place to start would be if I can ask the panel to introduce yourself and share a bit about your experience with the digital preoperative assessments. And then a second part of the question, how has implementing a digital approach impacted patient outcomes and streamlined clinical workflows? So Abby, could I start with you, please? Could I come to you first?
Yeah, hello everyone. So my name's Abby Burrows. I'm matron for pre-op prehab, and then it's the National Centre for Sport and Exercise Medicine, if people were wondering what that title stood for, and at Nottingham University Hospitals NHS Trust. So by profession, I'm a physiotherapist, and I work as part of a team of centralised preoperative assessment staff, and we're continuing to work through those solutions to implement the NHSE pre-screening and optimisation mandate. It is very much a group effort, and I only represent one of many in the team that are working on this. So just to give a bit of a background, NUH has got a centralised preoperative assessment service as well as an elective orthopaedic major joint replacement pre-op service, and then with a few very small silos of pre-op services across the hospital, little niches. We receive in centralised pre-op approximately 2,000 pre-op referrals per month and support, depending on how you break them down, 19 different specialties. NUH, so that's Nottingham University Hospitals, is currently a really fluid landscape, and I think that's me being very political in how I describe that in regards to its digital systems, and we're set to move to a new EPR programme by the end of 2025. This will impact outpatient areas in particular, preoperative assessment, as it requires a new electronic preoperative assessment from the one that we're currently using. And as an interim, we've been working with Isla to create a patient-facing pre-screening arm of the current preoperative assessment in order for us to work towards identifying the individual needs of patients, and both for lifestyle and medical optimization opportunities. So Isla have supported and enabled us to create our own bespoke pre-screening questionnaire, which we loosely based on that recommended by NHSE, and a bespoke RAG rating criteria to identify risk, and that was developed by our preoperative assessment head of service, consultant Dr. David Evans. The RAG rating flags to the team patients which may require earlier investigations and input than previously would have been possible, because we would never have known anything about them. It's afforded us the opportunity to recruit on a temporary basis initially, whilst we build up a business case, 2 perioperative care coordinator roles to oversee the coordination of the responses, and to reach out to patients who might not be able to respond digitally, and to refer onwards for lifestyle and any further medical investigations and intervention, following input with our clinical team.
Fantastic. Thank you, Abby. And Katie, can I come to you next, please, for an introduction, could you tell us a bit about your experience with digital preoperative processes, and then go on to how implementing a digital first approach has impacted patient outcomes?
Good morning, everyone. I'm Dr. Kate Misselbrook. I'm a consultant paediatric anaesthetist at Alder Children's Hospital. For those who maybe are not so familiar with some of the paediatric services in the UK, we're one of the tertiary centres within the Northwest, and we deliver general anaesthesia for approximately 20,000 children per year across approximately 16 specialities, of which some of them are quaternary level care with regards to spine, craniofacial and cardiac and neurosurgical services. So we are obviously purely paediatrics, and our service with regards to paediatric pre-assessment is definitely separate and about a decade behind what would have been adult pre-op assessment services. So our service was established in 2017 and has rapidly progressed since then, with expansion to all specialities and massively increasing volume of patients. Now, separate to adult services, where paediatrics, generally there's never really a question about like a huge amount of optimization and whether surgeries are going to proceed or not proceed. But what's really, really distinct about paediatrics is that we have large volume, and it's early identification of more complex patients that might need input, investigations and additional support on the day. So that's really the unique nature for us. Plus we have, given the complexity of the surgeries we do within our trust, we have a lot of subspecialty pathways that we need to filter these children into. So as we evolved, we initially were based on telephone triages. So we now operate with 9 full-time nursing staff across a range of bands. But as our service expanded and the requirement for what we needed to do with regards to ordering investigations, reviewing patients face-to-face, doing this for 1,000 patients per month expanded beyond our workforce capacity and wasn't the best use of our workforce time. Therefore, what we felt is that we needed to change our pre-op system from a telephone triage that then would filter into potential face-to-face to a new digital facing platform that then alters how we initially receive that interaction with parents. So we have designed an absolute bespoke e-health questionnaire with Isla Care, which is active but still in the trial process, which has allowed us to then send parents receive a text message the minute that the surgeons have identified that this patient is going to have surgery, with or without a date, that allows us then, not only do the parents get to tell us all about their child's medical history, but then from the answers over this extensive 17-page e-health questionnaire, we can then filter patients, triage patients into important subspecialty categories that allows them to then be either seen directly by consultants, be seen by nursing staff, highlight children with learning difficulties, highlight children with complex cardiac conditions. So it's given us much more visibility about the patients that are sitting on our waiting list to ensure that they're all prepared for the on-the-day surgery. It's avoided cancellations, improved the quality of care and support that we can offer for children and families leading up to surgery, identified problems with gives us much more time to identify any problems. And we also now, because a lot of our work is with about 60% of our work will be day case based procedures, there's often high rates of cancellation, increased high rates of cancellation compared to adult practice with, like, for example, common coughs and colds that children might suffer that cause their surgeries to be cancelled. We've got really robust systems in place for managing short notice cancellations and then also backfilling these lists. So it's improving theatre utilisation on the shop floor. For example, on a dental list, we can ensure within 24 hours if a case is cancelled, it can be replaced. So overall, it's really improved our staff efficiency for the large volume of patients that we face per month that need to be seen by pre-op, ensured that over 90% of all our patients are getting a triage or a pre-op, and optimising our short notice cancellation policy.
Fantastic. Well, sounds like it's had a significant impact in many ways, really. So thank you for that. It'd be great to go into that in a bit more detail over the next hour. But first, can I come to you, Lara, for an introduction, please, and hear about your experience with digital preoperative assessment and how implementing a digital approach, the impact that has as well.
Yeah, absolutely. Thanks, John. Hi, everyone. My name is Lara Mason and I head up the product team at Isla. more sort of generally, the product team is responsible kind of for understanding what we build and how we build it, really. So we spend a lot of time speaking with users, be those kind of current users, prospective users, to understand pain points, patient pain points, clinical pain points, and also to understand kind of pathways that patients are on, and to see how we could be implementing Isla's solution, kind of Isla's digital pathways in clinical practice. So Isla is kind of actually quite well embedded across perioperative pathways. We're used fairly extensively across post-surgery pathways, so for like remote monitoring of patients after surgery. But recently we've had a real focus on the preoperative side of things, because we've seen there's a real opportunity for a kind of scalable and efficient digital pathway in that pre-surgery space that would be able to support clinical and operational teams, but also patients as well. The other thing that's been really interesting to hear about is the potential benefit of standardizing that approach. So looking at how we can standardize sort of the pre-screening or pre-surgery workflows across the site or across the trust or even kind of across a region. And so you'll hear much more from Katie and Abby than from me about the sort of clinical benefits that we've had. But just to kind of highlight a little bit the work that we've been doing there. So having those patients be automatically contacted from the moment they're on the waiting list, it's got a number of benefits. Both Katie and Abby have touched on them. We've got the being able to contact the patients every 3 months or whatever it may be that's suitable for the pathway, allows us to satisfy that NHSE requirement for kind of contacting patients regularly, doing that waiting list validation, understanding which patients maybe have had their surgery privately or no longer require it. It also helps us to identify those potential risk factors. As Katie pointed out, in the pediatric world, it's kind of more about the risk factors than the optimization requirements. But in the adult world, being able to look at that lifestyle or medical optimization requirement and just try to kind of foresee any potential bottlenecks down the pathway and see if we can shift that kind of as early as possible down the patient's journey. And then finally, the kind of additional really nice thing from the patient side is we're able to facilitate that engagement with the patients. So they're kind of up to date, they're engaged, they're able to provide that information ahead of time. And we're also able to be sharing resources and guidance back with the patients while they prepare for their surgery or while they help their children to prepare for their surgery. And so you kind of see this really positive, we can talk a little bit more about patient engagement maybe later in the session, but we've seen kind of really, really great engagement from patients across these pathways. And I think that's indicated the real the drive of patients and patients' parents to kind of be engaged from as early on as they can be.
Fantastic. Thank you. Abby, can I come to you for the first question, please? So the question is, what role does capturing at-home clinical data play in identifying patients with preoperative optimization, and how can this streamline the pathway for both high and low risk patients?
Yeah, so hopefully this slide starts to answer some of these questions. So we launched, similar to Katie, we launched this as a pilot. So it isn't live with all of the patients. We couldn't possibly just go live with the 2,000 referrals per month. And the challenge you have is, do you do it from date listed and do day forward, or do you then do your look back for all of those currently listed? So that's been a real challenge for us. So we launched in June, and initially we focused on laparoscopic cholecystectomies, and the idea is we send the questionnaire out to these patients listed day forward. We did actually then do a look back and over time fed those patients into our system as well. So we had all in, but we did it in a staggered approach. So we didn't flood our care coordinator. We only had one at that point. So the idea is that we send a questionnaire out, which initially asked, do you still want the surgery? Now, for those that have just been listed, I would expect them to say yes. But for those that perhaps it's the look back and were perhaps listed a while ago, we have had some answers where they've said no. And that's because in the meantime, they've either had this done as an emergency and it hasn't yet come through on our system, or they've had it done privately. So it does help us do a little bit of a data cleanse as well. So they get sent the questionnaire, do they still want the surgery? And then if they say yes, it will then answer our bespoke screening questionnaire. So you can see that to date, we've sent it out to 736 patients. So we've sent a number more questionnaires out, and that's because these are now the 3 months and the 6 months that they're getting. So that's not, you can see the response rate is really quite high. which we've been really quite surprised about, to be honest. We do have to caveat that we're obviously only doing a certain cohort of patients, and that may change as the cohorts develop and we get different specialties. But essentially, we launched laparoscopic cholecystectomies in June. We then went across to all gynecology patients, and then we've just this week launched to all HPB and endocrine surgical patients day forward. We have had some challenges with our internal system as how we can feed Isla the data, splitting out the patients that are due to have general anaesthetic versus local anaesthetic, and that is a challenge that we're continuing to work on, and that's how we can break those down, so we're not sending LA patients pre-screening things unnecessarily, essentially. But you can see that we've identified since launch 21 patients who no longer require surgery that would have sat on our list, and we potentially may have contacted them or used time which we didn't need to. We've supported 38 patients for medical optimization. So this varies from blood pressure, uncontrolled diabetes, patients who need sleep studies and a risk of sleep apnea. We've referred 120 patients for lifestyle optimization. So that isn't just signposting them. We do actually physically put a referral in, and our care coordinators have a conversation with them in the moment as well. And that way in which that we can send messages to and from to the patients has been really helpful for this. We can send them information and upload that directly, and that has been really good, particularly for patients that are maybe working and accessing and answering the telephone isn't that easy, but the text messages come really well. And it's only very recently we've gone live with the low risk fit tags. So these are the green or the golden patients, as a number of us are calling them, that we would identify as low risk fit, so don't necessarily need any further intervention. Again, we're having challenges around how that translates across because of the different systems we're using. They're not able to communicate with each other yet. So that's still work in progress, but we can see where we can make improvements, and we were due to go live with patients that we identify as moderate risk and those that we identify as high risk, and we will use that to book them the appropriate appointment length. So we're using the right people, the right time. So those that need to see an anaesthetist, they get booked immediately as opposed to that delay.
Fantastic. Thank you, Abby, for taking us through the project. Katie, can I come to you next, please? Can we go and dig deeper into your programme at Alder? Can you take us through the digital pre-op process and how it works in a paediatric environment, please?
Yeah, so essentially at the moment, how it works is that children, we have an electronic patient record, and when the child gets booked for theatre, they fall onto a pre-op work list, and that work list is how the nursing staff are working through try and sort of do telephone triages and then identify patients who need to be seen in a nurse-led or a consultant-led clinic. But because there are so many of them, and we found that when we audited, about 20% of the time when telephone calls were made, parents weren't, obviously because they're working or unavailable, weren't returning a call. So then we had a whole new work list generated of, right, we're going to return your call tomorrow or the day after. So it was a lot of wasted nursing time, and also not a practical way for parents to try and share the information that they needed to do with us. So what we thought is that we developed an electronic health questionnaire that we can then text message, send this information out to a parent that they can then complete. So now our process is that all these questionnaires are completed by the parents. They're then reviewed by a member of nursing staff. And so everything is still reviewed by a clinician before a child will proceed for their surgery. So it's reviewed face to face. And then after that, there's either a decision that they're fit to proceed and they have no further intervention, or they'll have a telephone call just to clarify some information, having had an EPR review, that the nurse will do an EPR review for that child. If they are, for example, a fit and healthy child attending for an elective day case tonsillectomy, and the parents have not requested any further input from pre-op, it might be that is the end of the intervention from pre-op, and that the completed form will then automatically go from our Isla online dashboard to our electronic patient record, where the anaesthetist on the day that's doing the operation, anaesthetising the patient can look at the PDF summary. We've designed it that there's lots of questions, but at the bottom there's a nursing summary note, so that anaesthetist will know that the patient, those notes have been reviewed by a triage nurse and it's all signed off. So there's safety in place there. This, at the moment, we're about to literally hit the go live button for the entire services, but we've trialled it with our dental services. So when we released it 2 months ago, we sent it out to 261 patients. Over 100 questionnaires had been completed within 3 hours. So the impact meant we suddenly were overwhelmed with the fact that it was genuinely working. Parents found it very easy to get a text message, quickly fill out a questionnaire for their child. We've basically, from those 261, 147 required a further telephone call, and that might be just to clarify some information that was shared. We're clearly being very conservative at the moment. And then only one child needed a face-to-face nurse-led clinic appointment. So again, that was brilliant. And of this 261, which was the entirety of our dental waiting list, 190 didn't even have a date. So suddenly the dental service has got this bank of patients that we have said, these are all good to have surgery. And therefore that's what optimizes our ability, because there's a question on the health question that says, are you happy to accept a short notice scheduling date? And 184 parents said, yes, I'm happy to have a date at short notice. So at least we're not going to ask people, can you come in tomorrow for your child's dental extractions, if they've not said, yes, I'm happy to accept that date, or I'm open to a short notice date. The other big thing for us with dental patients, a lot of them that require general anaesthesia often have complex or challenging behaviour or learning difficulties, and they require either bespoke planning, they might require additional time on our theatre list to allow us to provide oral pre-medication and just safely and gently care for these children. Of the questions answered, 125 parents highlighted that their child had a formal diagnosis of learning difficulties, but 165 parents have said that their child does have some sort of learning deficit, and that might be that they've not got a formal diagnosis of an autism spectrum disorder, but they are not developing as they would be expected to develop. And that is really, really important for us, so that we can then make contact with them and, as I said, just see how we can improve their patient journey. And even though we've also got a question on the saying, does any parent want additional support? And 129 parents actually said, yes, we want extra support. So that's maybe a telephone call, maybe they want more information, but it means that there's a two-way conversation between us and the families and that's, you haven't even got your date for surgery yet, and we're able to address these issues. So even though we've done a very, very small trial, we've been overwhelmed with the impact. And not only that, the nursing staff find that even if they're then having to telephone a parent, they're doing it in a much more targeted way, rather than telephoning a parent, going through an entire whole load of questions on a e-health or on our current pre-op triage, and then having to document it all. So overall, we're sort of waiting for it to go live for all specialities, but essentially we'll be able to triage the entire waiting list of patients within a few weeks.
Fantastic. Thank you for that, Katie. I've got a quick question for you from the chat. Can you share the process and policy for short notice cancellations? How does that work?
So at the moment, essentially, once a parent identifies it, I'll tell you our current system. So we have, when the parents complete the triage, when we complete a triage, we still ask that question. If the parent, the PCOs, so if they phone up and say, right, the PCOs are like the surgical secretaries, if they're trying to book a patient on last minute, they basically have to go on to a triage completed for a patient and then see if that's a yes or no answer. So it's a really bulky step process. What we're hoping when and then the admissions team will contact the parents and say, are you prepared to come in? So it'll be a direct telephone call to try and get them in at short notice. And if that's a yes, then the admissions team are able to provide all of the fasting instructions that would be required to come in on the day. That's mostly applies to all our day surgery. So our high volume, high turnover work it doesn't really apply to our more complex all-day inpatient subspecialty activity. What we're hoping though with Isla Care is once a parent has completed on the eHealth questionnaire, we've got our own dashboards within the hospital that will allow us to essentially, our tech team can just pull out and highlight when a parent has said yes to that. So you can have a dashboard of all the specialities. So the dental secretary can select dental, and then she can select, said yes to this question. And then you're just going to get a list of patients that have completed a questionnaire who've also said, yes, I'm happy to be called. So therefore, as long as there's no other reasons why that patient couldn't be brought in at short notice, for example, they need a double slot because of a pre-med or a complex cardiac patient that requires a cardiac anaesthetist. But if they're otherwise straightforward, it doesn't require a clinician to be involved in the decision making of replacing essentially a like-for-like patient. So that will really work for us things like dental, ENT, day case, general surgery, or paediatric surgery, I should say. So those things will be really impactful, but hopefully we'll be able to be administrative-led rather than clinician-led.
Fantastic. Thank you, Katie. And Lara, can I come to you next, please? Can we dig into the Isla platform, and how does that help streamline the preoperative triage process and the caseload of patients? And also, how can that be tailored by specialty or cohort? And can you take us through that, please?
Yeah, absolutely. So streamlining is the right word to use here. It's something that we're really focused on. And I think I'll start by sort of breaking down how, so when we think of streamlining, we're thinking of gathering information sort of while the patients are at home, asynchronously. We're thinking about reducing bottlenecks, and we're also thinking about how we can be reducing unnecessary appointment times. I'll also touch on integrations because that's a kind of really key focus for us. But just to talk a little bit more about how the patients receive their questionnaires. So as we've kind of mentioned, the minute the patient's placed on the waiting list, or when they're sort of the message is sent to Isla, we send them a text. That text doesn't require them to log in or create an account or anything. They just verify with their year of birth or with their child's year of birth, and they're able to submit that questionnaire. As both Katie and Abby have alluded to, we've built bespoke questionnaires in each case, and so that's able to be really configured to the pathway. And in fact, when we receive that message saying send out the questionnaire on this automated pathway, we're also able to kind of triage based on the specialty or even the procedure. And so we are able to kind of build these base standardized questionnaires, make little tweaks based on kind of where there might be something specific to a pathway, and then send that out completely automated. So that means that from the moment the patient's sort of placed on the waiting list, there's no manual need to be sending anything out. That's completely automated. The patient also will receive some reminders if they haven't submitted. And there's also visibility of patients who haven't submitted, because we know that some patients perhaps aren't appropriate for a digital intervention like this. And so we've got kind of visibility built in of patients who might need kind of a different approach. Once that information is submitted into the questionnaire, we also have kind of inbuilt automations that might pick out answers that they've given that might be relevant. So for example, if the patient might say that they've got diabetes or that they smoke a number of cigarettes per day, we sort of automatically pick out those little pieces of information and create work lists of patients based on those. So to loop back to what Abby was saying earlier about the lifestyle optimization and medical optimization, if a patient has said, for example, they've got a high BMI, or that they sort of drink excess alcohol or smoke a number of cigarettes, they'll automatically have the lifestyle optimization tag applied to them. And it makes it really easy for teams then to be working through that list of patients, kind of having that dashboard cohort view of patients, which is something that we're kind of really focused on, giving that overarching view rather than having to work through kind of only an individual patient's response. Then to come to the kind of reducing bottlenecks side of things, again, this is all about how we can be pulling out that information as early down the pathway as possible, as I mentioned. So one of the things that we're working on actually with NUH is being able to automatically send a message back into NUH's systems when a patient is appropriate for lifestyle optimization. And so that would sort of automate the process even more, streamline the process even more. So if a patient has consented to being referred for something like smoking cessation and they're eligible for that, we can be automatically pinging a message back into HL7 through HL7 into NUH's systems and sending that off automatically. So we're trying to do everything we can really to reduce the sort of additional admin burden that sometimes might be introduced by a digital system and free up as much time as we can. Then just to talk a little bit about the appointments freeing up as well. So Abby mentioned RAG rating. We're doing the same at Alder as well, where we're kind of identifying risk levels for patients. And so what we want to be doing there is, are there patients who are eligible for a reduced appointment, telephone appointment, no prep at all, potentially just an HCA appointment. And so by having this information and by having these clinically led algorithms to identify that risk status for the patient, again, we can kind of have all the information ahead of time and help the patients to prepare for their pre-op as well. Just to talk a little bit more about the integrations side of things, it's something that we're really focused on, of course. So in the kind of full flow here, in the kind of ideal state, we've got a feed coming in from the site into Isla through HL7 or FHIR, which is just a standard way of healthcare messaging. And so when the patient is placed on the waiting list in an EPR or in a PAS, we automatically receive that message and we set the patient off on that automated pathway straight away. However, the way that we've gone live with a couple of sites and we're currently live with a few as well is we've got a setup that we call bulk upload, which allows us to go live straight away without having to rely on a feed. And so it's the way that we've gone live with the Alder pathway as well, where instead of having to wait to set up integrations, we can just upload the patient straight into Isla and they get set off on their automatic pathway straight away. So it's a really nice way of being able to see the benefits kind of from day one, while we can still look at building out the kind of more streamlined kind of longer term flow in the background. And then John, you mentioned tailoring, so I'll just quickly come to that. Isla as a whole, really, it's something that we're really proud of as a solution. We've intentionally built the platform to be very configurable. And so that means that if we sort of pull out of the pre-op space for a second, across kind of Isla's implementations, we've built it so that it's one core platform that can be used in a number of different ways. And we sort of do that intentionally because there's so much digital fragmentation in healthcare. And so we want to be kind of reducing that as much as possible. In the case here, we've heard both sites sort of have similar but quite specific questionnaires. So our pre-screening questionnaires are completely bespoke. They include things like scoring, those automations off the back of them, calculating things like BMI to reduce preoperative staff having to do that. And we even see sort of the benefits there. For example, in the NUH case, to come back to that, we've got the centralized pre-op questionnaire, but then we've also got, for example, the elective orthopedics team working from almost exactly the same questionnaire, but with just one question different to ask about patients having had a fall recently, because that's sort of specifically relevant to EO. And so we have this possibility here of having this kind of standardized approach with small tweaks based on the pathway, which we know from the procedure of the patient, and sort of enabling this very scalable approach across the site.
Fantastic. Thank you, Lara. And let's go to some audience questions now. So if anybody has any questions, type them into the chat, and we've got 20 minutes or so to go through those. The first, can I come to you, Abby, first, please? And keen to talk about patient engagement and what the impact has been on patients and how that take-up has been. And the question is, when you communicate with patients, how is that information available within the patient record to ensure visibility to all clinicians that need it? And as well, can you just take us through some of the patient engagement piece and what that has meant to patients as part of your project?
Yeah, so once a patient has responded to a questionnaire, that goes into the Isla Care dashboard. So it's up to us as a hospital trust as to who we give access to that dashboard. I think it's fair to say at the moment it is not integrated to the rest of our hospital EPR programme, of which we have hybrid model, hence why we're about to go centralised in the next year. So at the moment, we have only given it access to preoperative assessment because that's who's currently triaging and looking at these responses. So we will look at their responses, look at the automatic tags that are on them, and then filter by each tag and agree, confirm clinically or not clinically if that's correct, because sometimes we found patients haven't necessarily put the BMI in correctly.
Or we may have
actually when you
we may have lost you for a second there, Abby, just for maybe 10 seconds.
Okay, so apologies. So when a patient responds, sometimes some of their responses have potentially got some typos in, like BMI might have been miscalculated because there's a typo in their weight or their height. So we will validate that, and we can either take the automatic tag off because actually when it's put in correctly, they're within weight range. So we'll look at all of the responses and then make the appropriate actions. There's a way in which our Isla dashboard, we can write notes, so what's been done, and you can obviously see what's been sent to the patient through their system, but this is all on the Isla system. It is not yet integrated into the rest of the hospital system, and that's where I describe that challenge that we have at the moment, where we're identifying low risk patients, but at the moment we're not able to follow that through to let the rest of the hospital know, and certainly the anaesthetists and surgeons on the day, for them to see their Isla answers. So that's work in progress, and we'll be working with our new EPR provider and Isla to get that built in and integrated into the new EPR system so that can be seen, and then we can start to see the efficiencies through that.
Fantastic. Thank you, Abby. And Katie, can I come to you for the next question, please? For anyone on the call who's potentially looking to explore this, where do you think they should begin, and what would you suggest to them as their first step?
So, I mean, pre-op is always really challenging because with regards to business case writing, it doesn't often show with regards to being financially rewarding for the trust. And it's quite hard to prove, bar minimizing short notice cancellations, why taking on a new process would have such a significant benefit. So the starting process is working out what your trust needs. I looked a lot about our volume and basically staffing input and staffing hours worked to try and justify to the trust taking on a new business contract with Isla, how that was going to be significantly beneficial to improve our staffing utilisation and also the patient safety and just improve patient journey benefits from the health questionnaire, which is market huge. We all know how beneficial it is going to be. So I think the starting place has to be how it's going to trying to put some actual theatre utilisation and staffing efficiency numbers for your trust to prove the benefit. And then I know once we are established, which we now are, all the other huge benefits are going to come into play. And not only in the pre-op part of things, also the post-op follow-up. So bits that we're going to be able to look into is looking at the patient measured, recorded and outcome measurements from, a bit like Abby was sort of saying, is how is the ability to identify, for example, RAG stratify that all of the, 20% of patients attending our hospital for ENT surgery don't need any input over the telephone. They just need to do this eHealth questionnaire. How is their experience of that input? And then post-operatively send messages with questionnaires through the same basis to see their post-op recovery. So you start to build up, you develop a whole wonderful basis of data looking at speciality-based, past medical history-based, these complex children, how we just gaining all this data and this information, which the Isla platform is spectacular at delivering.
Fantastic. Thank you, Katie. And Lara, can I come to you next, please? Can we talk about integration and just talk about how the system and platform integrates, but perhaps with the healthcare system or other trusts that you work with, and also how does it enhance coordination between surgical teams?
Yeah, absolutely. So when we think about integration, there's data coming into Isla and then data going out of Isla. So on the data coming in, I've touched on it a little bit, but our kind of gold standard there is a direct integration. We've got a number of direct integrations across a number of patient records, or where that doesn't exist, just a feed, an HL7 feed, which is just a messaging system that allows us to kind of have updates when there are updates in the EPR. So for example, the action of a patient being placed on a waiting list triggers a message automatically into our systems, and we're able to receive that and kind of process it. The information that we get through a message like that is it includes things like patient demographics, if that patient already exists on Isla, or if it doesn't, we'll just create the patient. And then also in the case of something like this pathway for surgery, we'll receive things like the specialty, the procedure, the priority as well. And once we have that information, we're able to kind of utilize it in understanding which pathway the patient should be placed on. For the specialty piece of that messaging, that also tells us which, we call them teams on Isla, which team the patient should be put into. And that just kind of tells us who should have access to that patient. So we might have a dermatology team or a pre-op team or a dental team, kind of depends on how we're wanting to set up that collaboration between operational and clinical teams at the site. And so you can have a real mix of people having access to the patient record. And we have one Isla patient record per patient, again, trying to centralize that view of the patient. The patient may be on sort of 4 different pathways, and that's all visible from the same patient record. It links into this idea as well of because Isla kind of sits alongside your EPR and works to kind of boost up the EPR's capabilities, it links into kind of any patient record or any PAS across the NHS really. And so again, you can have this one kind of centralized record for the patient based on the different pathways the patient's been on. I mentioned as well, where we don't have that feed, we can be using bulk uploads. So that's kind of inbuilt functionality within Isla, which allows anyone to go live kind of straight away. So we've worked really hard to try and sort of think through where we might have slowdowns or blockers or kind of time that we might have to wait before I go live, and to think about how we can kind of mitigate that to start to see benefits as soon as possible. Abby touched on the data going out, so I'd like to speak about that a little bit. So something that we're also really focused on is trying to understand what we don't want to do is be siloing any data or sort of have people not have access to the right data. So again, a couple of different options here, but one of the things that we're working on is saving that structured data back into the PAS or the EPR. Again, kind of very specific to which site we're at, but as an interim as well, we do have kind of what we call contextual launches, where Isla kind of launches from within a PAS system, so that if you're on the patient's kind of record in the EPR, you can also see the patient's Isla record there as well. And then just to touch on what you said there, John, about enhancing coordination, Abby mentioned the kind of discussions that you can have on the patient record. But again, just to loop back to this idea that you can kind of have teams coordinating within one record, having kind of conversations. We've got kind of time and date stamp notes and conversations as well. You can be sharing that patient record with someone in another team for their kind of thoughts or their feedback in a secure way as well. So again, trying to sort of centralize those conversations. And as Katie mentioned, kind of having those all kind of in one questionnaire, kind of time and date stamp with notes there as well, so that when you're looking at that patient in a pre-op world, you've got all the information that you need in front of you.
Fantastic. Thank you, Lara. We've had a couple of questions come into the chat around how the platform works for people who English isn't their first language, and is the questionnaire available in different languages? So yeah, 2 questions for you there.
Yeah, of course. So on the kind of digitally illiterate patients or the technophobic patients, I'll just touch briefly on that patient flow. So we've intentionally worked really hard to kind of make the flow as light touch as possible. We kind of follow accessibility standards. So if a patient's got any kind of accessibility configurations on their phone, that will be reflected when they use the Isla link. Again, that sort of, we don't ask people to create accounts or anything like that, so that it's kind of as easy to do as possible. And I think that's really reflected in the response rates that we get. I'll just point briefly to the elective orthopedics workflow as well, where the majority of those patients are sort of older patients, and we're seeing 83-84% response rate across those patients, which I think again just kind of points to the sort of ease of the flow. There are, of course, patients who this won't be relevant for, or won't be sort of appropriate for. Maybe they don't have a smartphone that works, maybe they just don't feel comfortable. And so we do have that visibility kind of built in of, these are the patients who haven't responded, they've had their reminders, they haven't responded, and so they will need kind of another intervention. Regarding the language question, so it's actually, I don't think it's live for either NUH or Alder, but we do have questionnaires that are built in other languages as well. Patients can kind of open the questionnaire and then choose which language they'd like to complete in. That's sort of subject to building those alongside the client as well. But again, sort of trying to make it as accessible and as doable for any patient as we can.
Katie, can I come to you?
Yeah, I just wanted to come in and obviously address the same thing. So, I mean, bottom line is this is ensuring that we don't, there's always that concern around digital deprivation and language barriers, and ensuring our services are accessible for all. In many ways, was present prior to us moving to a digital eHealth questionnaire, in the sense that we still were doing telephone-based triages, not initially face-to-face. And what we have a place and process that the minute that we identify that the parents don't speak English as their first language, but we book a face-to-face nurse-led clinic to perform that triage. So we bring the children and parents into the hospital to make sure that we can use our language line services to get all the information, and make sure, more importantly, that the parents are fully understanding of what's potentially planned for the operation, etc. So we don't have the questionnaire in another language. But what we have got the ability to do is to, when that questionnaire gets flagged, identify that that parent doesn't have English as their first language. And then so now our process will remain the same, that we'll still book a face-to-face nurse-led clinic and use language line during that clinic appointment. So although we've moved to a new process of triage, hopefully the same support infrastructure is present for the parents that require that.
Thanks, Katie. Abby.
I was just building on that as well. So our perioperative care coordinators will pick up those that haven't responded, and we'll try and reach out to them. It will allow them to do it over the phone with them, so they can fill it in on their behalf, and we can document who's completed it. So we do have an option in our questionnaire for I'm sure similar to Katie, asking who is completing it and what relationship they are to the patient, so that we can use that as our medical record. And in the same way, our perioperative care coordinators would pick that up, and it would be documented that it's been completed by the perioperative care coordinator over the phone and asking questions. I mean, we have examples where we've even been able to reach out to patients in prison and work with their healthcare team and avoid patients coming in for a preoperative assessment who would have had to come in from prison. And that actually has saved a huge amount of money across the whole system, in all honesty, because the amount of coordination that's required to get these patients in is really tricky. And I think that was really well received. We do similarly in care homes, so we may reach out to care home providers or next of kin for those people in care homes to try and support people where possible to complete over the phone, and that again helps bring patients in unnecessarily for that. So that was just to say that our perioperative care coordinators will try and pick that up for us.
Thank you, Abby. Can I ask a question about the specialty you first started in. Why did you choose that specialty? And if there's anything you'd like to share around how you started and advice for people perhaps starting their journey, could you share that too, please?
Yeah, so in all honesty, lap colis were a nice group that we could identify relatively easily. They also had a very keen team around them that were really keen to be engaged and get going with it. So essentially, from a change management piece of work, we went with the flow and went with the people that showed the real keen and interest. We've then tried to be a bit more strategic with who we've extended out to. We've looked at those that perhaps have challenges when theatre scheduling and perhaps struggle with delays in patients being suitably or having suitable numbers that have preoperative assessment. So hence why we went out to gynecology. That can be really tricky. We were keen to go out to spines because we have we know that that's a really tricky group of patients that would benefit significantly from pre-optimization. The challenge we've had with that and why we haven't been able to go out yet is the difficulty between distinguishing, and that's in our hands as the trust, distinguishing between LAs and GAs in order to be able to feed those information to Isla for them to send the questionnaires out. So that's something that we're working on. But essentially, we've then started to look at those that struggle with either having the right patients ready to go at the right time, or patients that, or cohorts of patients that we know medical optimization and lifestyle optimization is particularly important, and that's how we've gone about it.
Fantastic. Thank you, Abby. Right, the next question. Katie, can I come to you, please? The results are very impressive. I appreciate that this is still early days. Do these patients need to have bloods or investigations that might expire before their date of surgery? Often the challenge is adults that have a telephone consultation may be sufficient for their medical history, but the 3-month expiry date for the blood group and save means the patient needs a visit. How are you managing that process?
So, I mean, this is going to be a new scenario for us because at the moment we're working much closer to date than the 3 months. So it is going to be new. We probably would, obviously the group and save, we'd need, for us, it's within 7 days for the second sample. So a lot of the patients do end up coming for 2 visits anyway for bigger major surgeries. Sometimes they get admitted the night before, so that might mitigate some of those scenarios. And then a lot of the other time, we might be happy to push out to 6 months. But because we're working off 2 systems, so we've got our own electronic patient records, but we've also got like an electronic dashboard where we, at the moment, track all the patients that are being booked for theatre. So, for example, say somebody has completed an electronic health questionnaire and they've not got a date for their surgery. We will then potentially get them in and do some bloods, do an initial group and save, but they will then come up on our system, you know, nearer the time, so they'll be reviewed. If the 3 months has lapsed, they might well be sent another e-health questionnaire to complete, and that's going to be automatically sent out through Isla Care, and it might be that that just needs a little bit of tweaking or just ensuring that the health of that child has remained stable. So that's more likely going to be occur for like much bigger surgeries, because I suspect the high turnover, large volume day case stuff, they get seen in clinic, there's not a long waiting list, they get booked, they get operated on, which is different to maybe, for example, spinal surgery, where we might know that we're going to do it for a year plus kind of thing. So yes, we admit that there will be potentially children having to have another repeat visit nearer the time for maybe not all blood work, but maybe a subset of blood work. For example, most likely having group and saves, valid group and saves in place. But we have got a backup system to ensure they're not missed, if that makes sense, because we have our active dashboard, which is like a giant calendar of every patient that's having surgery on that day. So that's constantly being reviewed. So there's no concern that we'll miss them, but hopefully we can rationalise. Even again, blood work for paediatrics. So echoes within the last year. So again, generally that should be fine. But blood work, sometimes we're trying to get a lot of blood out of a child that's maybe a mixed venous and capillary samples. So if we've done all the venous sampling further away from surgery, it might be that they just need a capillary sample for a repeat group and save, which is obviously less invasive and unpleasant. Yes, it means an extra visit, but sometimes it's also just rationalising what also needs done.
Thank you, Katie. Abby.
I was just looking at some of the questions around sort of patient experience and supporting people's technological needs and digital literacy. We actually passed the questionnaire through as a mock with our patient experience team in the trust to get their input and to give us any sort of feedback. And actually they were really positive about this. I think the one thing that probably haven't emphasized is that it comes through as a text message, and obviously they can click on the link and you do complete it on their smartphone. But those that don't, you do have an option to be able to send the questionnaire to yourself once you've received that initial text message to the an email address that they put in. So it will come out on text, but it says if you would rather receive this, and I'm sure Lara will give more information, but if you'd rather receive this or view it on your desktop, so those that would rather use their computer, they can put in the email address and send it to themselves, essentially in that link. And that was really popular with some of our patient
We might have just lost you slightly there, Abby. So again,
Sorry.
we lost you for 10 seconds. It wasn't long.
Apologies. Some of them may put their sort of relations or wife or brother or son down so that they can help them complete the questionnaire. So I think that was something that I think has been really popular and perhaps has supported some of that improved response rate.
Fantastic, thank you. Right, we've got a few minutes left, so I'd like to ask you all if you could share one takeaway from today's discussion or a key insight that you'd like the audience to go away with. Katie, could I start with you for that one, please?
I suppose the key takeaway from paediatric pre-assessment is that for us, it's about risk identification of more complex patients to streamline them away from children that are very fit and healthy and potentially need minimal intervention. So it's a much more extreme form of pre-op than the adult population from that perspective, and that we're dealing with large volumes of children, and that we also want to seek the questions and responses from the parents that they're more involved in their child's healthcare and upcoming surgery, and to ensure that they're very informed. Isla Care is allowing us to have that two-way conversation with parents and also start to finally risk stratify some of these patients to improve our combination of day case, theatre efficiency and utilisation, but then also separate out much more complex patients that require more time and planning prior to coming in for surgery.
Thank you, Katie. Lara, can I come to you next, please, for a key takeaway?
I think for me, the thing that I feel really excited about is just the patient engagement that we've had to date. And I think we've kind of heard that from paediatrics, from Katie's experience, from the centralized world and Abby's world, and sort of even the older patients and, for example, orthopedics. We're seeing this huge range of patients, sort of huge range of demographics and ages, and yet we still see this really consistent buy-in. And so that kind of tells me that we've got a really sort of solid base to build from, and it makes me feel very excited about the kind of potential for scaling this across kind of more use cases as well.
Fantastic, thank you. And Abby, can I come to you, please?
Yeah, I think for me, having spoken with Emma McCone, who's the GIRF National Lead for Preoperative Assessment, and from our work with the National Non-Medical Preoperative Assessment Network, I think it's fair to say that digital challenges appear to be the biggest blocker at the moment around implementing pre-screening and optimization. For us, it certainly has been a real wicked issue for us at NUH, and it is definitely a journey of perseverance and resilience, and probably, in all honesty, compromise as well. And I would just encourage anyone who is on this journey, and we continue to be, to think outside the box and perhaps lean into more innovative solutions and continue to knock down the doors, because it is a challenge, and I think you're not alone, and we're certainly still experiencing those challenges.
Fantastic, thank you, Abby, and a nice message to close the webinar on. We are just coming up to time, so I'll look to close the session here. If you have any questions outside of the session, feel free to email myself, john@htn.co.uk, and I can coordinate any questions that you might have or connect anybody. Like I mentioned at the start, the session has been recorded and there will be a write-up so you can read about the key discussion points in a summary document, and we'll share that in the next couple of days. So that is it for now. So I'd like to say thank you to Katie, Lara and Abby for a fantastic session. It's been a pleasure, and thanks for joining us. And thanks to everybody in the audience for your questions, and thanks for joining us too. So let's close the session here. Thanks everybody, and have a nice day.
Thanks all.
Thanks. Cheers. Bye.